Hi, my name is Jenna, and this is my patient care presentation for the Critical Care Nursing elective course. First, we'll start with some background of the patient. The patient was a female, 58 years old, and she was a full code. She had a medical history of multiple myeloma, heart failure, deep vein thrombosis, hypertension, and chronic pain. She had a left chest wall port and an intrathecal fentanyl pump for her chronic pain. She was on a nicardipine drip for her hypertensive crisis with a systolic blood pressure goal of 160 to 180. The day I had her as a patient, she had daily labs drawn, and some of the abnormal values were her white blood cells and her BUN and creatinine. The patient was originally admitted to 4 South from the emergency department for the maintenance of chronic pain. Her urine sample that was collected in the emergency department tested negative for fentanyl, even though she had the intrathecal pump. After a few days in the hospital, she started to have increasing altered mental status. At that point, she was then stat called and transferred to the medical ICU. She was only alert and oriented times 1 to 2. She could tell her name and that she was in the hospital, but could not say which hospital. She was started on a nicardipine drip for hypertensive crisis, and clinical opiate withdrawal scale was also initiated every 4 hours. While in the medical ICU, her intrathecal pump was interrogated by the manufacturer representatives. They found it to be working, but the pump was empty. It did not have any fentanyl in it, which would explain why her urine tested negative for fentanyl. She was also started on PO, roxicodone, and IV Dilaudid for her chronic pain because at first IV Tylenol was prescribed, but that did not do anything to help her chronic pain. At this point, physicians started talking about the possibility of PRES. PRES stands for Posterior Reversible Encephalopathy Syndrome. Some signs and symptoms are headache, seizures, altered mental status, and vision loss. It is characterized by white matter edema affecting the posterior occipital and parietal lobes of the brain, which are found on a CT or an MRI scan. Some causes include infection, sepsis, shock, autoimmune diseases, chemotherapy, and hypertension. It has also been found in some pregnant women who have preeclampsia and eclampsia. The pathophysiology of PRES is still unclear, but there have been some hypotheses that have come from studies done. This syndrome has been reported in all age groups, but mostly affects middle-aged adults, and it also mostly affects females. Some comorbidities that can increase the risk of developing PRES are bone marrow transplants, organ transplants, end-stage renal disease, and lupus. This patient presented to the hospital for an inability to manage her chronic pain. Even though she had an intrathecal pump that administered up to 30 micrograms of fentanyl per day, she still was experiencing an increase in her pain, which shows that the pump was not working correctly. A new study done by Tumenta in 2021 shows that PRES might possibly be caused by a sudden opiate withdrawal. Opiate withdrawal can cause altered mental status, which is why COWS scale is usually implemented for these patients every 4 hours, and was also implemented for this specific patient. Altered mental status caused by withdrawal could also be confused with altered mental status caused by PRES. PRES appears to be reversible, but a delay in diagnosis can have a negative consequence for the patient. There needs to be a collaborative care model between psychiatry and neurology for this diagnosis and management of the condition. For this patient, a CT scan was done, but no conclusive results were found that would indicate that PRES was causing all of her symptoms. An MRI was the next step, but unfortunately I do not have the results of the MRI because the patient was transferred out of the medical ICU before the MRI was done. The care plan for a patient with PRES would be as follows. Step 1 would be imaging. A CT and MRI scan would be used to determine if PRES is the cause of symptoms. Step 2 would be to control blood pressure with medications, for example, nicardipine like was used with this patient. Step 3 is to implement anticonvulsive therapy and seizure precautions. Step 4 is temporary renal replacement therapy if it's required for the patient. And step 5 would be continue monitoring imaging for reversal of cerebral edema. I only took care of this patient for one shift, so I can only speak on her plan of care for that one day. The physician was wanting to get more imaging done on her head to determine if PRES was the cause of her symptoms. Her blood pressure was being controlled with a systolic goal of 160 to 180, and they were continuing to decrease that throughout the day. She had seizure precautions in place to reduce injury or harm if she were to have a seizure. Temporary renal replacement therapy had not been talked about yet, but could have been the next step. Our plan of care for the shift for this patient was to help manage her confusion and reorient her when needed. We were also starting her at-home antihypertensive medications so she could get off the nicardipine drip. Once she was off this drip, she could possibly transfer to a med-surg or telemetry floor. To achieve these goals, we used the clinical opiate withdrawal scale to assess her confusion throughout the shift. Because of her confusion, it took her a while to agree to taking her PO antihypertensive medications. But once we finally were able to get her to take those, we were also slowly titrating down on the nicardipine drip. We were able to completely get her off the nicardipine drip so she would be ready to transfer to another floor. But her confusion and altered mental status did not change. She still remained alert and oriented times 1 to 2 throughout the entire shift. This is the nursing care algorithm that I came up with for PRES. This would be used if a patient is exhibiting new onset neurological symptoms and they have any of the comorbidities or causes that are related to PRES. First, laboratory values like electrolytes, complete blood count, and medication levels would be checked. Then neuroimaging would be done. First, a CT scan would be done. If PRES is not identified, then an MRI would have to be done when the patient is medically stable. Then you would trend the patient's vital signs. If hypertension is present, then you would begin aggressive hypertension management with medication. Following that, further assessment would be done as clinically indicated by the patient. To summarize the patient's history, the patient presented to the emergency department with increasing chronic pain. She had altered mental status and a hypertensive crisis during admission. Then she was transferred to the medical ICU after a stat call. Her confusion and agitation continued, and the patient was not able to communicate her needs easily. Diagnostic studies like blood and urine cultures and X-rays, ultrasound, and CT scans were done. Her blood pressure was managed, and there was continuous monitoring of her mental status. Her attending physician was the one that suspected PRES first and brought it up to the care team. Before she was transferred to a telemetry unit, we never got any conclusive evidence that proves that she had PRES syndrome. I found this patient to be very interesting because I had never heard of PRES, and neither had some of the nurses in the medical ICU. I wish the care team could have gotten some better answers for this patient and her family and seen her get back to her baseline orientation status before she left. Here are my references that I used throughout this project. Thank you.